Thanks again for having me. And as you mentioned, I'm one of the infectious disease attendings here at Mount Sinai Hospital. I'm currently directing antimicrobial stewardship, but I've always spent a lot of time practicing HIV medicine, both in the inpatient and outpatient setting. So looking forward to speaking with you all today about HIV and viral hepatitis in the workplace. Apparently, I gave this talk last to this group in 2016. So sort of hoping to update on what's evolved in the past decade or so in terms of prevention and treatment. I don't have any disclosures. And our objectives today, so we're really hoping to primarily review the risk of transmission of HIV and viral hepatitis in the healthcare setting, which is a question I think that comes up relatively frequently still in employee health. We'll review the guidance on post-exposure prophylaxis primarily, though I'll briefly touch on pre-exposure prophylaxis, really just sort of what's evolved in that arena over the past 10 years or so. And then speak about recent updates in HIV and viral hepatitis treatment, because we have made so many strides, and I think that really does impact on the current guidance around workplace-related exposure. So we're going to keep it case-based. The first case is a transplant surgeon who contacts employee health. She was stuck with a needle while performing a liver transplant overnight on a patient with HIV. The patient is engaged at Sinai, so well known to us for their HIV primary care, and is thought to be well controlled. And I think the questions for us are, what's her risk of contracting HIV from this exposure? And should we be offering post-exposure prophylaxis? So wanted to just contextualize for a minute with sort of where we're at with HIV epidemiology. Again, it seems like I last gave this talk about 8 years ago, and luckily we have made significant progress since then. So at that point, in the 2010s, we were really talking about around 50,000 new cases of HIV per year in the US. And we sort of got stuck there for a long time. But really in the past 5 to 10 years, we've seen a decrease and a decline that's illustrated here from 2018 to 2022, about 30,000 new cases per year. Of course, that still means we're seeing 30,000 new diagnoses of HIV per year in the US, which is disappointing, and we'd like to continue to get that down. But it is progress from where we were before, and that's been due to a number of modalities, including PrEP, and the concept of U equals U. So really undetectable equals untransmittable, which means that the patients who know that they have HIV are in care, get on treatment, and get undetectable. We really know from the data that we have now, particularly for sexual exposure, those patients are not going to transmit to someone else. The big piece of this, as I mentioned, though, is knowing one's status. About 1.2 million people live with HIV in the United States, but for every 100 people with HIV, we estimate that about 87 know they have HIV, and there's 13 or so who don't, which means those are people who are presumably viremic, who are not on therapy. So another major facet of ending the HIV epidemic is really increasing the number of people, the percentage of people with HIV who know their status through routine testing, so that those patients can get on therapy and get undetectable. And then the last point I wanted to make about the epidemiology is really that, while there are a number of people living with HIV in the US, because treatment is so effective at this point, people are living longer and they're aging. And so that means that in the hospital setting, we're going to see a lot of people with HIV for a variety of things. Most of our patients are not admitted with HIV-related complications. They're admitted with other medical issues. And that can lead, unfortunately, at times to potential for occupational exposure. So how do we think about the first question with our transplant surgeon, which was, what's her risk for contracting HIV from this event? The CDC has this table, which some of you may have seen in the past, comparing exposure events and risk of HIV acquisition. And I would say to take this with a grain of salt, because some of this data is old at this point, but I think it's helpful in terms of understanding the sort of relative risk of HIV acquisition, really sort of for comparison more than for the hard number. But understanding that the risk is really influenced by two things, and that's the type of exposure. Some exposure events are inherently much riskier, blood transfusion being the riskiest, but risk also varies with type of sex act, et cetera. And then the other piece of that is really the viral load. So the amount of virus present is, of course, hugely influential in terms of the risk. And I think luckily what we're seeing is that as many patients are on therapy and that therapy is extremely effective, the viral load is often low or undetectable, and that is really helpful in terms of reducing risk. So just to break that down a little bit further, factors that may increase the risk of transmission, like I said, I can't overstate really the high viral load. And we know we'll talk about this with viral hep as well, but really the higher the amount of virus there, the larger the risk of transmission. In terms of sexual exposure, presence of a concomitant sexually transmitted infection can also increase the risk. We say acute or late stage HIV, that's been quoted. Again, I think that really gets at the viral load. At times with advanced disease and late in illness, the viral load can be high. And then in occupational exposure, we know to think about factors that can lead to a greater amount of blood, are going to lead to a higher exposure risk. In terms of things that will decrease the risk of transmission, so again, antiretrovirals, because they're bringing down the viral load. In sexual exposure, male circumcision, there's data for, and condom use, of course, can decrease transmission risk. And we'll talk about pre and post exposure prophylaxis. This is from the CDC. And again, they'll say the chance of occupational transmission varies by the type of exposure. I would say the sort of overarching point, though, is that the risk is low and these events are exceedingly rare. A lot of the data that we have, again, is really based on events that took place in the 80s and the 90s, and we'll get into some of that literature. But really, in the past 20 years or so, there's been really minimal reports of HIV transmission in the occupational setting, and we'll talk about why that is, but in large part due to our advances in therapy and the role of prophylaxis is another part of that. Thinking about exposure risk, so splashes being very low risk. And needle stick injury, what's quoted is often sort of vaguely less than 1% or at times 0.3%. Again, I would say that that number is based on data that at this point is a bit outdated, and some more recent series have suggested that it could be even lower than that. So what do the guidelines say? Post-exposure prophylaxis is recommended when occupational exposure to HIV occurs. Really, it's our job to determine the status of the exposure source patient to guide that need for PEP. And we'll talk about this, but if the source is not of HIV, then PEP does not need to be continued. We do want to start PEP as soon as possible after occupational exposure. And we know based on the data that we have that really the PEP is most effective early on. It should be ideally within 24 hours. Can be up to 72, but the sooner the better. And it should be continued for a 4-week duration. There used to be guidance that's now outdated about PEP regimens that had fewer than 3 agents, but at this point and for some time now, the guidance has been for PEP regimens to contain 3 or more antiretroviral medications. And we'll talk in more detail about what those are. And then there are times when expert consultation is recommended, when it's worth it to reach out to ID. And I think this is when we normally hear from you all, and that's generally when there's concern about whether standard PEP is appropriate because the source patient might have resistance to antiretroviral agents. Maybe they're taking a regimen that's atypical. Sometimes that requires some digging on our part to understand why they're on an atypical regimen and tracking down old resistance studies. If the patient is struggling with the PEP regimen, then that could be another reason to bring us in or to refer to ID. If the exposed patient has serious medical illness, that might make it challenging to take the PEP or maybe leads to an atypical PEP regimen being used, for example, in end-stage renal. Or other issues that we've listed, including, the PEP is offered late. This is from the HIV guidelines, but again, just sort of emphasizes the need to start early and why we do this in terms of, HIV transmission and establishment of chronic infection. So after an exposure, the virus does start to replicate locally in tissue cells of the exposed individual. Ideally, we'd like that PEP to be administered, like we said, very early, certainly within 72 hours. And at that point, replication can be blocked and infection can be contained. If it's delayed and replication is not blocked, then unfortunately what happens is within 48 to 72 hours, we do start to see replication in lymph nodes. And then this leads to viremia within 72 to 120 hours. in the exposed patient, and unfortunately then infection can be established. And again, I think this is something that's quite a rare occurrence in the occupational setting, but there's a huge role for PEP non-occupationally when exposures can be high risk in the setting of unprotected sex, and when PEP really needs to be given quickly to be effective. Where does the evidence for PEP come from? So I think it sort of goes without saying at this point that we can't really do a randomized placebo-controlled trial to study PEP efficacy at this point, right? We know that ethically we're obligated to offer PEP. We know that it works, and we would not want to wait and see what happens to someone who's been exposed to HIV. Also, since the relative risk of HIV acquisition usually from these events is relatively low, it would require large numbers to get such a study done. So the data that we have generally comes from animal models and from extrapolating from other areas of prevention, really perinatal prevention. So in terms of animal transmission models, we have good data from macaques. This goes back now some time, showing that agents like tenofovir blocked SIV, sort of the equivalent of HIV infection, if given early and continued for 28 days. It was less effective when delayed. And we've seen this again when other PEP agents have been studied. Macaques, similarly, who were exposed intravaginally, were offered protection with a 28-day course of PEP. And there's been a pooled analysis more recently of all of the animal studies that are out there, reporting the risk of seroconversion was 89% lower among primates exposed to PEP. So really sort of good data from our animal models. And then we've got the perinatal literature, and I think perinatal prevention of mother-to-child transmission of HIV has been one of the sort of biggest successes in the HIV prevention world. We know that the combination of pre and post-exposure prophylaxis to the neonate does reduce transmission. In terms of occupational medicine specifically, so sort of a landmark study that was a case control study published in 1997 in the New England Journal, and this is where a lot of our understanding comes from. As I mentioned, we're luckily not experiencing this anymore to have ongoing cases for the most part. So we have to look back to this older literature to see, what did occur before this was well understood. In this case control study, there were 33 case patients, over 600 controls. The cases did become seropositive after an exposure to HIV in the workplace. And the risk factors that were identified for HIV transmission now sort of make intuitive sense to us, right? Deep injury, visible blood on the device, a procedure involving a needle in the artery or vein. So all sort of factors that would lead to a higher amount of blood, terminal illness in the source patient, so a higher viral load. And then what was protective was the post-exposure use of zidovudine or AZT with an odds ratio of 0.19. So that's where a lot of our understanding and support for this guidance comes from, that you can imagine that using our current antiretrovirals would be even more effective as we're using 3 modern agents, which are more powerful, potent than AZT alone. So getting back to our case, the source patient's chart was reviewed, and she's on Biktarvy. Her last viral load was 240 copies, so not quite undetectable, very close, but maybe gives us a little pause. What's the recommended PEP regimen for this employee, and how should she be counseled regarding the potential side effects? So we go ahead and offer PEP, and we know that their 3-drug PEP regimens are recommended now for all exposures, as I mentioned. The preferred PEP regimen for an otherwise healthy adult is a nuke backbone of what we call Truvada, tenofovir, and emtricitabine, given with one of 2 integrase inhibitor options, so either raltegravir or dolutegravir. And an alternative can be a protease inhibitor-based regimen, that we really do try to avoid protease inhibitors at this point, given the side effects and drug interactions. This is a sort of busy slide, but I think comes from the HIV guidelines and the New York State AIDS Institute. And I think it's just helpful sort of as a reference and algorithm. Again, just emphasizing some of what we've talked about, but really, our first dose of PEP should be given as quickly as possible. If the source's status is not known, then of course we're trying to get testing and confirm. If the source patient is known to have HIV, then again, a 28-day course of PEP is recommended with an integrase-based regimen. In terms of how well our current PEP regimens are tolerated. These are regimens that we're now prescribing routinely in practice, and our patients generally have very few side effects to integrase-based regimens. I think certainly there are fewer drug-drug interactions. Usually side effects, if they occur, are quite mild. So usually GI side effects, nausea, vomiting, diarrhea, some headache or fatigue. One can see myalgias, and rhabdo has been reported with integrase inhibitors and with RAL, but that's very, very infrequent. And we do make a recommendation to avoid the interaction of iron supplements or divalent cations with dolutegravir or raltegravir, because this can interfere with absorption. The literature that's out there suggests that completion rates of the 28-day course of PEP is significantly better with these newer regimens, with integrase-based regimens. It's still kind of a wide range of completion rates, and I think adherence can still be a challenge, but generally in the sort of 57 to 92% range, whereas with the older regimens was reported to be as low as 40%. I will say that we all are awaiting sort of the next guidelines on PEP regimens and anticipating that a single tablet regimen like Biktarvy is in our future. I think that will be much, much easier for occupational PEP, for NPEP, to offer one pill once a day to patients, as opposed to struggling with the twice-a-day raltegravir or even the two-pill combo of Truvada and dolutegravir. So I think we're hopeful, but that recommendation has not been made yet formally. So I did not include it here, but we're hopeful that that's coming. I think this is something you all know because you do this routinely, but the baseline and follow-up testing from the guidance is, a fourth-gen HIV test at baseline. That's the antigen antibody combo, along with CBC, renal function LFTs, hep serologies, pregnancy testing if appropriate. Really, the counseling, I think, is huge. There's so much confusion around PEP. I think patients in the initial moment are often very overwhelmed and anxious and might not fully get sort of the need for the 28-day course. They're often in the emergency department when that happens, or some other kind of urgent setting. So making sure that that's well understood. And the guidance from the state is, ideally to provide as much of the supply as possible, certainly a starter pack from the get-go. And then follow-up testing is recommended at 4 weeks post-exposure and 12 weeks post-exposure. I wanted to just take the opportunity to update on HIV treatment, which I think is something that you all might be a little bit less exposed to, but I think certainly influences this discussion around post-exposure prophylaxis and the risk of transmission, because we've made so much progress in how we treat our patients with HIV, and it is much easier for patients to be undetectable on therapy. So at this point, the guidance is that ART is recommended for all persons with HIV, regardless of T cells, regardless really of any other factors, because it reduces morbidity and mortality in the patient themselves, and also because we know it prevents transmission of HIV to others. So again, that sort of U equals U, undetectable equals untransmittable, was really kind of a groundbreaking finding in HIV medicine, and meant that it's a public health concept to get people on therapy, because it means that they're much likely to transmit HIV to people that they're interacting with and could potentially transmit to sexually. The guidance is that data is really based on sexual exposure. ART should be initiated as soon as possible. So this is the other thing that's evolved. We don't wait, and that can be as soon as same day. So in many public health settings, patients are tested and they're offered immediate antiretroviral therapy. And again, that's based on data. I didn't go through it here, but I think to sort of sum it up, it's really that patients who start ART immediately are more likely to link to care and to suppress quickly. And again, it's sort of all about bringing the viral load down. The recommendations around treatment regimens are much simpler than they have been in the past. It's really that most people can be offered Biktarvy, is I think the easiest way to think about it. It's one pill once a day. Another option would be Truvada or Descovy plus dolutegravir, which is 2 pills, easily tolerated. And then in certain cases, so patients whose viral load isn't very high off the bat, who don't have Hep B co-infection, and in whom you have some resistance data to know that they don't have resistance to either agent, we can offer Dovato, which is a 2-drug regimen. And those are the initial recommendations. So again, has become sort of increasingly straightforward. Lots of regimens we used to use, we just don't recommend anymore. And that's mostly because it's not so much that they didn't work as much as that we have better tolerated options now. Um, so no longer recommended as initial therapy are things like, well, raltegravir, which we see used in our setting in PEP, but has a lower barrier to resistance, and it's, 2 pills, so higher pill burden for the patient. Elvitegravir and cobicistat, so those meds are in the combo of Genvoya or Stribild. You'll still see patients on that combination, but it's not something we would generally start off the bat because of drug-drug interactions with the cobicistat. The protease inhibitor regimens like atazanavir, no longer really do we see many patients on this due to toxicities. We can see a hyperbilirubinemia with boosted atazanavir that patients was just sort of very bothersome to most patients. Efavirenz, so that's Sestiva. That was in the first 1 pill once a day, which was Atripla. Again, huge when it came out, but that was 20 years ago, and associated with toxicities, particularly neuropsych side effects. So has really fallen out of favor. And regimens that are rilpivirine based, like Odefsey or Complera, also not popular anymore because of drug-drug interactions, food restrictions. They need to be taken with food. They interact with proton pump inhibitors, which so many patients are on. And patients don't do as well with higher viral loads. So I wanted to just mention briefly, sort of on the new frontier in HIV medicine that you might come across, is that we do have long-acting injectables available now for patients. And this is sort of an increasing project in the outpatient setting, is managing our patients on long-acting injectables. We don't provide them in the hospital. I'll sort of explain a little bit, but these are an option for optimizing ART regimens, basically for patients. The recommendation was initially for patients who are undetectable as a switch from an oral regimen to long-acting CAB and rilpivirine given every 8 weeks. They're given in the office as injections every other month. So in terms of pluses, this is very convenient for some patients who would prefer to come into an office setting every other month rather than deal with a pill every day, particularly patients with pill fatigue. I think they're very helpful with patients who have a lot of stigma associated with their diagnosis, don't want to sort of face it with the daily pill, or have disclosure issues around having a pill in the house. Then this can be really very important as an option. Some limitations. So again, you got to be able to come in every 8 weeks, and that is, just more challenging for some people than a daily pill. They are not active against Hep B, neither agent. So we have to be very careful with making sure our patients don't have Hep B co-infection and can't have resistance to either agent. There is a recent recommendation to consider these agents for patients who are viremic, so not undetectable, which was the initial recommendation, but really struggling to get undetectable, particularly if their T cells are falling and they really don't have other options. So we're sort of working on that and fleshing out who the best patients are for these agents, but an important kind of agent of the future. Okay. So moving away from our first case, the second case is a relatively quick one. But a medicine resident presents after a needle stick while drawing blood from a patient on his inpatient service with HIV. He reports that he's stable on oral PrEP, the resident is, and has been on PrEP for the past 2 years. The viral load of the source is undetectable. Would you recommend PEP in this case? And what options are currently available for PrEP? So I don't know if we have any thoughts. But the answer is that people who are already using PrEP typically do not need PEP, right? They're already on a preventive therapy to prevent HIV acquisition. So I listed here some other scenarios in which we wouldn't recommend PEP, just sort of while we're talking about this. We've already said if the exposure was, if the report is delayed and we're now over 72 hours out, it's generally not recommended. And if it was non-blood contaminated secretions that one was exposed to, then it's generally not recommended in that setting either. Things like urine, saliva without blood involvement, sweat, tears, etc. In terms of PrEP, I'll keep this brief because I imagine this is not something that comes up as frequently in the employee health setting, though potentially there are questions about this. And I think, again, just important to sort of know what our tools are at this point for preventing HIV. And certainly we have a number of employees who could be taking PrEP, and this could be relevant if they do have a workplace exposure. So current options for PrEP are now oral or long-acting injectable. And the oral options are Truvada or Descovy, but it's important to keep in mind that the data is really for Truvada in all people at risk for HIV acquisition, whether that be through sex or potentially injection drug use. For Descovy, which is the TAF-based option, considered usually because it could have less nephrotoxicity, less bone toxicity, but the data is in sexually active men and transgender women, not for cisgender women at risk for HIV through receptive vaginal sex. So just an important caveat there with the oral meds that are currently available. Similar to what I mentioned with long-acting injectable treatment, we have long-acting injectable PrEP. So IM cabotegravir, which was one of the agents in the treatment regimen, is the brand name Apretude, is available as PrEP. It's given every 8 weeks, again, on site in the office. So that can be challenging for some folks, but it is actually more effective than daily oral PrEP. And that's because PrEP is sort of all about adherence. It works as well as people take it. And the fact is that having an injection on board for 8 weeks is means that there's no question about taking the daily pill. And so for some people, that can be a way to really make sure that the adherence is kind of taken off the table. Okay. So moving into the third case, and shifting gears away slightly from HIV for a minute. A nurse presents to employee health for follow-up after an ED visit. She was seen in the ED Friday evening after a needle stick during a cardiac cath. The source patient has a positive Hep C antibody and has no record of prior therapy. Hep C serologies are done, Hep B serologies are done as well. And the source patient is Hep B surface antigen negative, Hep B core positive, and Hep B surface antibody positive. Baseline labs on the exposed employee were done, and the employee's Hep B immune. She's concerned about transmission of viral hepatitis. How should we counsel her? So again, looking to our guidelines, sort of a busy slide, but essentially our job is to sort of get a sense of the source patient. The source is, available for testing, and let's say the source is antibody negative. Of course, we're done unless we think there was a recent high-risk exposure. The source is positive, then our goal is really to figure out the RNA status of the patient. And this is because, a large number of patients at this point can have Hep C antibody, but not be viremic. And in this case, then would not be a concern in terms of transmission. About 20% of people who are exposed to hepatitis C, who contract hepatitis C, can spontaneously clear. We think 20%, although honestly, it might even be higher than that. And then we know that we have a number of agents available for Hep C treatment at this point, but patients post-treatment are going to stay antibody positive for life. So the presence of the Hep C antibody doesn't necessarily mean that this source patient is at risk for transmitting to the employee. Rather, we need to know the RNA status to understand that risk. If the RNA does turn out to be positive, then unfortunately, we're going to have to follow in our exposed patient LFTs and RNA to see if they then contract Hep C, and we'll talk a little bit about this. So Hep C is transmitted primarily through blood, but it can be very small amounts of blood, and so this can unfortunately be through even shared personal items. We counsel patients who have chronic Hep C not to share things like razors or toothbrushes with people in their household. And there can be sexual contact transmission that's been reported, particularly if there's blood involved, or this has certainly been reported in the MSM community where there's been acute Hep C that's been recognized and treated. The risk of transmission is in the occupational setting greater than the risk of HIV. And it's quoted as being probably after a needle stick around 1.8% compared to what we mentioned for HIV at 0.3%. And again, I would say to take those numbers, with a grain of salt, but I think understanding the sort of relative risk. There's insufficient data, unfortunately, about Hep C PEP, but if it's recognized that acute Hep C is diagnosed, a patient should be referred immediately to a clinician for treatment. And the good news is that we have a number of agents, which we'll talk about, that are extremely effective at this point in treating Hep C. A couple sort of interesting notes about Hep C epidemiology right now. I think, we saw a huge peak in Hep C incidence in the 80s and 90s that really plummeted in the early 2000s, but unfortunately have seen a sort of increase in, the 2010s to 2020s, due in large part to the opioid epidemic and to injection drug use. And what we see in terms of prevalence is that, I mentioned we've got a number of agents that can treat Hep C, but we still see new infections. So we've got new infections, some folks clearing on their own. We said probably about a fifth of people who end up with chronic Hep C. And then all of these people should be offered treatment. Treatment is highly effective, and that's fantastic, but reinfection remains a risk. And so people who have ongoing risk certainly can be infected again. And unfortunately, some people can go on to develop, usually over years, cirrhosis, hepatocellular carcinoma, complications of chronic Hep C that can lead to death. So kind of a complex dynamic with Hep C prevalence at this point. In terms of the positives, in the past decade, we've really sort of just seen a complete evolution of how we manage chronic Hep C. Really starting in 2014, we had easy access to direct acting antivirals for treatment. And originally these were used with interferon and then subsequently really without, which makes them much easier to tolerate. And the newer regimens require generally 8 to 12 weeks of treatment. They have very few side effects, and almost everyone is cured. So this is fantastic. The easiest, there are fantastic Hep C guidelines that you can easily access on the internet and go through and sort of assess, is my patient someone with cirrhosis? Have they ever been exposed to Hep C treatment? But for most patients, an adult with chronic Hep C who doesn't have cirrhosis, who's never been treated, there are two main options. Those are glyceprevir pibrentasvir, which is brand name Mavorite, given for 8 weeks, or Sofvel or sofosbuvir velpatasvir, brand name Epclusa, which is given for 12 weeks. And that's for all genotypes. And that's how the majority of patients can be treated. I would say more complex cases, of course, are seen and managed through hepatology, but treatment exists that's highly effective for the vast majority of patients. We don't need a significant amount of lab monitoring on these therapies. They're generally very well tolerated, but what we look for is the hepatitis C viral load and LFTs done 12 weeks post-treatment to make sure that the patient is undetectable. We call that the sustained virologic response, and that's consistent with the cure. So getting back to our case, we had our initial source patient who had a Hep C antibody positive, but RNA undetectable. And again, that's fairly common scenario, meaning no risk really to our exposed patient. And just to sort of put it out there, and complicate the case a little further, what if the employee had not been Hep B immune and the source had these serologies? So now the source is Hep B surface antigen positive, surface antibody negative, and core positive. So this is consistent with someone who's likely chronically infected, and that would be more concerning to us in terms of transmission. I'll talk just briefly about Hep B. I think Hep B is kind of a talk in and of itself. It's a very complex virus, and our hepatologists are often the experts, but I think just some key concepts that are relevant while we're talking about exposure prophylaxis. So the risk of Hep B transmission from occupational exposure relative to what we've been talking about is significantly greater than HIV. It does range, and that depends on viral replication. From 1 to 31%, but it can be transmitted, through percutaneous mucosal or non-intact skin and exposure to blood or body fluids. That can even be in the absence of visible blood, and it can be sort of hardy and remain on environmental surfaces for a prolonged period, which can complicate things. We think about the Hep B E antigen as a serologic marker of high viral replication and viral load. And again, similar, I think, to the way we talked about HIV and Hep C, it's the viral load that really leads to the transmission risk. So again, the risk is higher in someone who's got high viral replication and probably that E antigen present. Luckily, we have fantastic tools for Hep B prevention. You all know and are well versed in the vaccination. I just, for the sake of the case, proposed someone who isn't immune. I guess we can think theoretically that maybe that's someone who was a non-responder, or perhaps someone who had declined the vaccine. And in that case, then we do have HBIG, right? And HBIG is immunoglobulin available to us as another tool to decrease transmission. And this is a reference in the CDC, very helpful table. I'm going to mention in a minute our first line app, but we are constantly updating our stewardship app, and we're planning to put a lot of this post-exposure material as well onto the app. I think this is a super helpful reference. But you can sort of look and say if someone is non-immune, hasn't responded, does get exposed, then the recommendation would be for HPIG as another tool. Okay, so this is our final case. The final case is an OB/GYN intern who comes to employee health for his annual assessment. He discloses to the provider that he has HIV and is in care and doing well. What's the hospital's role in managing that potential exposure risk in this setting? And are there any restrictions that are generally recommended in terms of practice? I had talked about this when I gave this talk the last time when I looked back at my slides. And I think, at this point, again, like with the advances that we've had in treatment, I think all of this has become much lower risk and in some ways much more straightforward. But there were updated guidelines put out by SHEA, the Infection Prevention Society, in 2022. So I reference those here. I think that that's a good resource if you're interested. They go into some detail about recommendations for management of healthcare professionals that are living with Hep B or Hep C or HIV. And again, sort of remarkable and most interesting is how rare any transmission events are at this point. So for Hep B, we have 7 FDA-approved agents for virologic suppression. I didn't get into the Hep B treatment here, but most patients are managed with tenofovir or TAF or entecavir orally. And there have been only 2 patients since the 2010 version of these guidelines with a transmission event from a healthcare provider. In terms of Hep C, we just went through the direct acting antivirals, again, cure rates of nearly 100%. And so per SHEA, there have been 3 instances of Hep C transmission from a healthcare provider to a patient, again, in the last decade or so. And in terms of HIV, really no cases of transmission. I think this all speaks to the importance of knowing one's status. I think these cases of transmission usually occur from providers who are unaware of their status, not on treatment, and so not able to have the viral load suppressed. The recommendations for the healthcare organization are really to counsel practitioners that, if they're engaging in exposure-prone procedures, of the need to know their status, sort of similarly to how we talked about HIV generally, right? And the most important piece is just sort of knowing so that we can be on the right therapy. Providing access to the vaccine, which you all do, and making sure that people respond. And then creating protocols for, the event of potential exposure and knowing what to do when that happens. And then the last piece, and perhaps, the most involved in some ways, is the recommendation for an oversight panel that really manages and sort of tracks any healthcare provider who does conduct exposure-prone procedures and is living with Hep B or Hep C or HIV. In terms of practice restrictions, the guidance really goes to great lengths to emphasize that there shouldn't be undue restrictions on providers, but that we should make sure that any providers who are functioning in an exposure-prone setting is keeping a viral load low. And for Hep B, they draw that line at 1,000 international units. For Hep C, it's undetectable, which is easily achievable with our meds. And HIV, it's suppressed, which is typically less than 200, although I would say our lab detects to less than 20 at this point, and that's really our expectation. Okay, so just wanted to sum up. HIV transmission remains a risk to employees in the occupational setting, although I would say, a low one, particularly with the advances that we've had in antiretroviral therapy. Most of our patients are well controlled, and that transmission risk is really attenuated. Prophylaxis, post-exposure prophylaxis can further mitigate that risk, and recommendations are to offer a 3-drug regimen to ensure that happens. And then viral hepatitis, unfortunately, is considered more transmissible than HIV in the occupational setting, though we've seen really remarkable progress in terms of therapy, which have led to very high cure rates in the setting of Hep C. In Hep B, we have the additional tools of vaccination and HBIG, and so that really should reduce transmission. And finally, we in the stewardship group did develop this app. I'm not sure if you all have heard about it yet, but it is sort of all of our ID guidance. Again, we are constantly updating it, and so for any number of things that can be useful. We're going to add some of the PEP and PrEP, et cetera, guidance, but it does have sections on other, common infectious syndromes, info on antimicrobial dosing, info on pathogens, et cetera. You can use the QR code. It's our Mount Sinai content, so sort of specific to our pharmacy group's recommendations. But if any of you haven't seen it yet, please go ahead, and it's I think a useful tool.